Okay, so let's get started. Hello, Samin. I don't see Anu. Can you hear us in the cath lab? I'm used to having people turn their backs on me. This is nothing different. Okay. Hello, Mount Sinai. Can you hear us? Okay. All right. We know the first case is supposed to be a MitraClip. And there's a second case where they're doing a TMVr. Maybe this is the valve and ring. I can't tell.
Oh, MitraClip.
This is the clip.
MitraClip. Yeah, this is the case of the mitral clip. Everybody else ready?
Oh, you're going to do my talk first? Okay.
Okay. Can you hear us? Can you
All right.
the volume?
Wait. Can you hear us in Sinai?
We can hear the volume wise, just trying to adjust a little bit.
Okay, there we go. All right, great.
What about Stan? You have the mic? Get the mic so everybody get ready?
We can hear you fine.
Yeah, okay, good.
So let us know what you're doing.
Okay.
Tell us about the patient.
Yep. So what we'll do is, while everybody getting in from their lunch break, I'm glad that actually everybody got ready very quickly. We showed 3 cases of various kinds of the surgical and tower prosthetic aortic valve. And now we have 2 cases of mitral, followed by our last case will be another tower. So this case is the case number 4. We can show the slides, please.
I think they have a different room here. We are showing a different room. This is the wrong room.
Right. So Samin, I think we're seeing the opposite room. So if we need to, there we go. Okay, now we're seeing the case.
Good. Okay. So we are on the case. Good. So this is the case number 4. These are disclosures. So it's an 82-year-old male, has a severe dyspnea on exertion, with New York Heart Class 3, actually also had a CAD. This patient is mine for many, many years. I've done the PCI in the remote past and always have a severe LV dysfunction, was managed by anti-ischemic therapy as well as heart failure. So a few years ago, he has no longer ischemia, he has heart failure, so I assigned the patient to our heart failure team, which has been managing this patient with a reduced ejection fraction, with their optimal medical therapy and so. So this is, and of course, as you saw, the majority of the patients get the ICD and CRT, and the patient continues to be in heart failure, symptom now class all 3 and dyspnea on exertion on maximum medical therapy. So for that purpose, the plan was that knowing that this etiology is the moderate to severe mitral regurgitation of functional, which is your co-op trial type of patient with left ventricular end diastolic of 46 millimeter, systolic of 54, and end diastolic volume of 90. So then we just go with the TE while everybody else is getting in. So I'll give it to Stan, our echocardiographer will comment on what we are seeing here.
Yes.
So we can go live TE echo, please.
Yes, what's the first one?
Stan, yours.
Yes. So this is a mixed pathology valve. As you can see here, we have a pizza of 1.1, ERO of 0.35, and the regurgitation volume of 65 ml.
Okay.
You can see the valve, the leaflets are thickened. There is some prolapse of the P2 scallop. And this is a true view image of the mitral valve.
This is SL1.
And you have 2 distinct jets of regurgitation, one in the medial part and one on the center part of the mitral apparatus. So the mean gradient through the mitral valve is 2 millimeters mercury. So that's about, Dr. Sharma, we are ready to go. Good?
Okay. So maybe a quick discussion. So the EROA is 35 millimeters squared now, which is good. I mean, that's right in the moderate range. On the slide, it was 23 millimeters squared, and I was a little wondering about that. Is there pulmonary systolic venous flow reversal?
There's systolic flow reversal in left upper pulmonary vein.
Okay. So that's clear that this is severe MR. So I want to ask the panel, maybe I'll start with Seibel. So Seibel, is this functional MR or is this degenerative MR?
There's another term, functional, by the way.
Dumptional?
Yeah. Just for billing reasons. You know, I didn't see all the pictures, but there did seem to be a bit of a prolapse of the posterior leaflet.
Yes, there is
And
prolapse of the pedal scallop.
pedal scallop. And so it's not like classical functional MR.
Right.
Yeah, I think most likely is not most likely is mixed pathology. The ejection fraction is a little bit low, 35%. The ventricle is a little bit dilated. And,
Yeah. You see how the P2s there prolapsed?
Yes. But you don't see an eccentric jet, you only see two jets coming straight at you.
Yeah, but then if
So-
it's eccentric, if it's truly eccentric, directed posteriorly, then I would say it is clearly functional, restricted posterior.
Right.
But here it's going straight up. But it could be just prolapse, because prolapse, you don't necessarily have to go to wall hugging.
I am not sure it's a prolapse. If you
I-
look,
yeah.
I am not sure it's a prolapse. Because
Or it's just
absolutely no MR jet
right there.
to show that it's a prolapse. The
That's
two
right.
jets you see is coming straight up, whether that is.
I mean, there may be some restriction of the posterior leaflet.
a cleft somewhere.
But yeah,
Because
it did look like there might be a small cleft. So, but this is not uncommon that there's a mixture of etiologies.
See, there I just thought there was an
So,
overlap.
but the patient's got heart failure, the ejection fraction is 40%. It's severe, it needs to be fixed, and I
that's the
think
odd
this is a very reasonable approach. Was this patient a surgical candidate? Was there a heart team discussion about possible surgery?
Yeah, into quite a bit. This surgery actually was never, surgeons back even a few years ago before the heart failure team took over. That time was the discussion, and it was left only for medical management from the heart failure.
Okay.
And said that at that time we did the CRT, and it was just left that once become refractory, will become part of the mitral clip. So this is actually took about 3 to 4 years.
See there how the
Okay.
people are behaving.
Did okay, medical therapy and CRT, and then finally
Yeah.
broke through. And with the result, now patient actually, the only symptom patient is functional with age of 82, and felt that this is now the right approach for this patient.
Is the patient AFib? Or had AFib?
The patient actually based originally was in AFib. We have to look into.
Because Manny is thinking that this potentially could be atrial functional MR, right?
Yes, I think that is the likely possibility, because even though there's a history of coronary disease, the posterior leaflet doesn't look particularly tethered.
No.
It's actually very mobile.
Yes.
So I think the primary mechanism here, which explains the jets,
Right, two jets.
two jets, right central jets, is
Right.
probably a dilated annulus with a big LA
Right.
from either paroxysmal or history of AFib.
Yeah.
That's what I think.
I'll get to that answer in next 3-4 minutes. We'll just go back to the old EPIC data, and
Yeah, we'd like to see, if you can, the annular dimensions, and just to see how big the left atrium is. There could be a component of that as well.
Did you see that?
But I think there was a little bit of restriction of the posterior leaflet. It's, so, I mean, there may be multiple mechanisms here, which is not that uncommon. And again, even, with, go ahead.
Yeah. Okay, so you stand
Yes.
by cable view, right?
Yes, by
You
cable
start
view.
seeing coming down.
So tell us about your technique to puncture the septum. Where are you going for? And you're doing it echocardiographically guided.
From posterior, I think you can see here as I'm coming down, but we have a Baylis needle, which will be easy to track. You should be able to see the radio opaque tip. I keep coming down now and then, checking on the fluoro. You still don't see me, right?
Not yet.
Yes, I see. Yes.
Well, we see it, yeah, we
Yes.
see
It's
it.
very high, yeah.
The
but you can
tenting
see
is in the, it's in the thick part of the septum,
No,
not
we
in the
see it
fossa.
We see it on the echo,
And it's in the short axis, it's actually quite anterior.
yeah. Right, so you'd like to be posterior and superior.
I'm in the right spot now. What do you think? More posterior?
Yeah, you're very.
No, you are very posterior
Low.
already, yeah.
But you're very low on the bicaval view.
Yeah, here. I see here.
Here, we're not,
You,
We are posterior? Okay, I'm
Or,
no, just advance the TE probe, see how it's higher, or advance the needle up.
we're not seeing
Either of the
the
two.
needle well here.
okay. Now you're good. You can see me there.
Yep.
Yeah.
what does it look in the bicaval view?
Just
You
do.
want to
The bicaval view, yes. The bicaval view.
You are a little low, yeah.
Bicaval is very low, right? It should be a little bit high.
It's still enough height for the posteriorly, so it should be okay. But if you can go a little bit up, it would be better in my mind.
Can you give us a height? Give us a height. Yeah.
Yes.
Yeah, so there's a good chance you're gonna need two clips here. So, I think the position of the puncture is pretty important.
Okay. Can you give the height?
Yes, I'm giving the height now.
Then you have to go up again. Saibal, you think too inferior? You want me to go up again?
Yeah, I think you should go up a little bit. Yeah.
4.1 centimeters.
4 point?
4.1.
You might be
4.1
okay.
is okay.
You wanna try to go a little higher? Saibal, push to hold when you speak.
I think you should go a little bit higher.
Okay, then we'll go back up.
One other way is just to turn a
You-
little
you-
more
you don't have to-
anteriorly and
yeah.
just push it up.
Yeah, yeah.
If you turn anteriorly, counterclockwise.
You don't have to listen to
You
me.
don't have to put the wire.
Now it's too anterior.
Yeah.
It's good. Flush again, flush. Okay.
The issue is that it's a lipomatous septum, so
Yeah,
All fossa.
Can we have the thing up? Okay, it's too low.
explain please. Superior. Yeah, superior.
That's good, enough.
Okay.
Yeah. Okay, I'm going posterior here.
And slightly lower, just a little. One.
uh,
Okay.
yeah,
You take
that's,
it.
Yeah, I think that.
Just take it.
it's actually a very small, fossa. It's a small landing zone to puncture, so,
Shimura.
4.1 last time.
I'm sure when you started Transeptal, you never did it like this. Do you think this is too much? Right.
yeah.
And makes it safer? These will. Yeah.
Yeah, it's definitely safer doing this echocardiographically. I think we don't see tamponade nearly as much as we used to. And usually with a big fossa, you've got more degrees of freedom here.
Okay.
Yeah, where?
I'm a big proponent of echo guide.
The size.
Push, Saibal, push to hold.
No, I am a big proponent of echo guided, and like Rick, I also trained in India when I did my mitral valvuloplasties, and we didn't have echo,
Yep,
and now I think I've changed.
Can you show
Yeah.
it now? No, you can't see us?
It's up there.
Huh?
It's up there. It's up there. It's up there. To posterior. Yeah. Okay.
No, I think it's just the go anterior, posterior.
It's up there.
It's just the maybe go inferior, thicker part.
But is it the right spot?
I
4 points.
that's probably not quite as high. Maybe so.
Four.
That's about the same as before.
4.3.
Well, this view is for short.
4.3.
Yeah, but
You-
from the middle of the higher, you have to really see it. It's probably
Get the catheter 4 centimeters, and there are also tricks to gain height. So, any other option?
Yeah, I think it's good.
Okay,
I think it's
I
good.
think we take it right, guys?
Yep, we're happy.
No, I think before you puncture, you should see the, where you are before you puncture. Just let him see you because it is in the very inferior thick part of the septum.
Can we explain that, please?
ready to burn.
No, you're, okay, they're saying inferior thick part.
Okay, now,
Yeah.
yeah, good. Yeah, you can burn.
Now you can see where you are exactly. You're ready.
Okay, go burn, burn,
No, you have to advance the needle.
8 feet.
I thought.
Okay, there.
Burn again.
Burn again, we are through.
No.
There.
Okay, good.
We shouldn't.
Okay,
It's
now you're
true,
through.
right? Yeah. Like Samir was saying, is very important that you should never be absolutely in the posterior thick part because you can have what is known as a stitch effect, when you can actually go outside from the right atrium, outside in the pericardial space, into the left atrium. So you should avoid being absolutely in the thick part, but rather be in the junction of the thick and thin. Is that what you were trying to say, Samir?
Right, and that happens mostly with mitral stenosis where the atrium is very, very big and right atrium is not that big. Both atria are big, then it's usually okay, and this is particularly atrial MR, so both atria are big. But again, that's a very dangerous area. And surgically, it's very hard to repair because you have to repair from inside, because if you puncture there in the
That's the waterstone
It's,
growth, right?
yeah, it's not a big deal, but it is still you have to go and pump. You cannot repair it from without being pumped.
Right.
I have wire.
The
Do
wires.
You
you
can
see
pull
the
them apart.
hemodynamics, right? Is it on the side, hemos? Okay, yeah.
Okay, so the sheath's out, wires in the left atrium.
So we have the confida wire. You see the confida wire, it's in the left atrium. Same, in the past, they always wanted us to go to the upper pulmonary vein. Right now, we just leave it in the
Right.
left atrium. That's it. Yeah. Now we have to make sure our ACT is good. Once the ACT is good, see, one thing I think they did show you, they have a figure of 8 here in the groin. He's going to hold it. We had a 14 French sheath that's coming out, and then we'll go up with the
Move this out.
yeah, then we'll go with the steerable guide catheter.
Hold the wire. Yeah.
So it's really important to check the ACT at this point. We've been having a lot of variability with heparin lots.
Minakam,
Yeah.
ACT?
And nationally, there's a lot of variability right now with
Yeah, there is a huge variability. We have also encountered it and looking into it, actually,
Yeah.
research-wise.
Yeah, as a surgeon, I always ask where the heparin is sourced. There's porcine and bovine, and we had some issues. The hospital is switching the source, entire hospital, and affects some of us doing surgeries as well.
Appendage, just be careful.
What was the question, Saibal?
It's in the atrial appendage.
Yeah, the wire is in the appendage.
Yeah.
Virus in the appendage, okay, good. So I think I want to get a ACT number before we go up with the sheath. So we go waiting. Okay, so it's going to take some time.
You can go put the sheath, right, because the wire is already there.
Yeah, I think you should advance the sheet.
You can go up with the sheath, I think.
Same thing. We're going to put some water. We're going to,
If you divide $600, right?
What's that, Saibal?
What is the price of this wire? I know.
If you have to
350.
ask, Saibal.
Use a super stiff wire, just $40.
You can, I
I know
like,
it's New York. Everything's very. You guys are paid very highly, so it's okay.
I use the Torre wire, and it is $80.
Yes.
It looks very similar to this.
You see me coming across.
Okay.
I'm just rotating a little bit.
Yeah, you might feel some resistance there.
Yes.
You may want to put little negative so that it
It's
doesn't
going.
jump. Yeah.
It
Yeah.
went through.
I think we could.
Perfect. Looks great.
Yeah.
That's
As soon
nice.
as you said little negative, we went through. Okay, we go to new. Wait 1 second. Just enough. So echo is saying 1 centimeter of the guide is across, which is about right. Okay, good. Coming out. We have ACT number? Okay, not good yet.
Are you using the Gen 4 or the previous version?
No, this is still going to be XTR or NTR.
Okay.
N4? I thought you're in New York, so things everything.
That's right.
What do you want?
This air.
Okay, we are
So the question is that whether you put a NTR or XTR. My personal choice in this, because there is a scallop in the P2,
Yep.
and then P3 and P1 both are relatively small, and there is a cleft between the two.
Right.
So one option is to put the clip from P1 to roughly little bit towards the A1, A2 junction, and the other one from P3, so bring the two posterior leaflets anteriorly, or the other option would be to just put a clip from the P2 to A2. My experience, it works better if you put it from the most medial side of
Yeah.
A1. I want to ask Saibal that how he plans it, and maybe NTR is better, XTR is going to be too much for this case.
So would you plan on 2 clips here? You've got 2
I would,
separate
yeah.
jets, and I suspect if you just do one central clip, you're not going to get as much MR reduction as you'd like.
The wide jet, if they had the generation 4, I would have used an NT wide. One NT wide in the middle.
We are going to start with the lateral jet
Okay.
and we go with the XTR. We are introducing the system now. Yes, good. What
So
do
you
we
can
see?
see we connected the side port to the hemodynamics as well.
Yeah, and usually it works very well.
And would your approach be different, Saibal or Samir, if you were using Pascal or Eberhard?
I would not, I have used a few wide clips. For this particular purpose, I'm not so sure that it would be a big help, because I don't think one clip is going to do it, because there are 2 different areas which are leaking. They're not confluent to each other. They are in 2 different spots, and both spots are on medial and lateral side of P2. So where you put a clip is an interesting question, and I think how I look at it is to say that where you want the coaptation line. So you want the coaptation line to move anteriorly, and so how do you make it happen is, I think, by putting 2 clips on 2 sides of A1 and A3.
Yeah.
Okay, the clip is coming out now on floor. You can see that.
Watch you.
Okay.
I wouldn't use an XT.
I agree with you that I think the XTR as one downside is that it makes the clefts bigger, right? Because it's going to tug the leaflet up. So when you have clefts, it is trickier to use the larger clip.
We have straddle.
Yes.
Yep.
You're going towards posterior wall.
Posterior, okay.
Yeah, you're
We're
close to
going
the
to
wall.
start
The
putting
posterior
the
wall.
M knob. Retract. You think I have to straddle more? You don't see it. No? A little bit more straddling? Yeah, okay. Just keep giving the M.
Excuse me, do you guys use the 3D images?
We
Yeah,
can,
he
we
does,
can,
he
we can
does.
use 3D to steer, but we typically, if there's
I think
not a problem, we just go 2D and we are already close to the bow. So
Mm-hmm.
we used 3D to get the trajectory
yeah.
before entering the LV. Okay, we have nice M now. Stamp,
Yes.
how does it look?
Looks good.
There's a little bit of map on floral too. You can see it's a landmark.
A little bit more.
Good M.
Okay.
We are good.
Yeah.
We are going to go to the lateral jet first, right?
View and just see what the jet looks like.
Yeah.
You'll have to see the jet.
Anu, can we just see a bicommercial color view to just see what where the jets are maximum?
Give them the bicommercial view.
Okay.
Yeah. So you're right. So you're going after the lateral jet first?
Yeah. I think we are right about the lateral jet now.
Yeah.
So Stam, if you just roll the TE in your hand, go a little posterior on the intercom, because you want to make sure the origin, there are two origins of the jet. I suspect there's one big pizza. And you see two jets in the atria, but it may be one single origin. You got to be careful, because sometimes we think it's two jets, it's not two jets.
Yeah, Mania,
Anu.
with the X-plane all along, all across. And,
Now that's a little more convincing, I agree, there. If you keep rolling it in that direction, Stam, keep rolling it. You want to make sure that all the way posteromedially it is two jets. Otherwise, it'll become one jet at some point.
But the 3D view are very convincing that there are two jets.
yeah,
That's where you saw it nicely. And even if it was one long jet, it's a very long coaptation line. I think you're still going to need the two clips.
Have a better plan as to where you want to
Yeah.
go. I agree. I mean, you may require two clips anyway, but
This is not uncommon that you go medially when you open the clip, so you may want to let go a little bit of.
Okay, now we are across the valve. Okay, we are adding plus so that it becomes
you're still on the,
perpendicular.
still in the LA, not in the LB yet.
Can we do some 3D?
Yeah.
Stamp shows the 3D.
Yes, I'm doing now 50.
Yeah, so you can see our transeptal height is reasonable.
Lower than what we
but
normally
we're low,
want.
but this is what we could get based on the
Septal anatomy.
septal anatomy. You can see we're right on top of the valve. We're pretty much center.
We have to go lateral now. Wait.
I'm going to open the clip at 60 just so that we can see the clip arms.
Yeah, you're exactly perpendicular to the commissure, as you can see. You don't have to. You don't have
Okay.
to.
Slightly clock it, I think, yeah.
I'm going to.
No, I think it's 12.6. I think stand in rotated quite at where it's supposed to be. Commissure, it's the horizontal, but I think this is right at 12.6 orientation.
But
think,
12.6,
Sam?
I agree 12.6, yes. And very perpendicular
Yeah,
to the
I think we can go back to 2D and go forward. So what we do also is we rotate the C arm to take the parallax out from the clip. So we,
Okay, I'm going to enter the LV now, okay? Posterior.
so the floor will allow you to make sure that your trajectory is still good. You're not diving medial or lateral. Looks like you might dive medial based on the trajectory I'm seeing here. Yeah.
Okay.
Yeah.
I'll get enter into the LV now. Medial.
Yeah, I think this looks about right. Yeah.
There you
Okay, we're in
go.
the ventricle now.
Now you're in the ventricle.
Can we get a better bicommissure view, please?
Yes, we are a bit squeezed here, but we'll try to get there.
You can see our clip didn't spin very much, just a little bit, so we can.
See how it's dived medially?
Yeah, a little bit. I think that's what we noticed. Our M is not even that much. It's only around 3 o'clock.
I think you should pull back the whole system and take off a little M.
Yeah, I think so.
Okay, we are now at 2 o'clock and 1.
Yeah.
This M is at 1 o'clock now.
And you should check the orientation of the clip again. With the long arms, it's very important to check orientation above the valve, below the valve, and after grasping, because otherwise you'll pinwheel the leaflets when you grasp it, and actually it'll cause distortion. So it's very important to be orthogonal to the line of coaptation at every time. Yeah, that's good. Yeah, it's good. It's very nice, actually.
We also do it on floral too, so yeah.
I think that this
That
is
looks
nice
pretty
and
good.
nice. Where we
I
want
think
it,
it's
yeah.
okay, maybe
Here.
a little bit counterclock, maybe a little bit,
Counterclock, we just did it.
Little
You
bit.
want us to counterclock more?
little bit, maybe,
Okay.
little bit.
We did it. Yeah.
Okay. That's perfect now, perfect.
Okay.
Perfect.
2D.
So we are going to start pulling back, okay?
That looks pretty nice.
Okay, show me.
You should check the
Yeah, now
commissure
it's,
color. It's a bit too lateral. So I would check the color in the commissure view before you grasp, because you may be too...
Color is there.
Okay.
What do you guys think? Color off now?
It's exactly on
I
the
think
color.
it's okay.
Exactly.
Yeah. Color off, please.
Yeah.
Yep.
Okay, I'm going posterior.
Okay.
Just a little bit, yeah.
Both leaflets.
You can
No,
see we
I
ran out of
cannot-
room.
We ran out of room. I cannot pull back anymore. Okay, I'm a little bit anterior, right? You want anterior better grasp?
That looks pretty
It
good.
looks good, yeah. I think you can lower it, the grippers.
Yeah.
We're going to drop the grippers now.
Drop the grippers. Good. Nice.
Okay, that's
We-
nice.
we
It
need to
looks,
see- We need to see the posterior, please. We
Right.
can't see the posterior.
You see the posterior there?
Okay,
Okay, it's
steady. You
bouncing,
see it,
okay.
yeah, bouncing, nice.
Yeah, we're going to close and then we'll try to
No, your gripper is not fully down.
It is. Okay. We're going to advance the clip a little bit as okay. Yeah.
you have the posterior, you happy with that?
Yeah, I think it's good.
Yeah.
I think we need to get more posterior.
Yeah, it's,
Yeah. I don't think we have enough posterior.
that
Now
was,
close it a little bit so you will see a little better, because I think, and let him analyze it. Yeah, that's good.
that
See,
looks
the
a little
posterior
better.
is
Yeah,
there
that
because
looks
there's a
little better there.
shadowing, yeah.
Yeah. Anterior looks great.
Look at the residual leaflet length. It's almost a centimeter. The total, what was the total leaflet length, Sam?
1.7. 1.7.
1.7. So I'm not sure we have all 9 millimeters of insertion in there. I think we should go and open and just talk a little posterior to have a more better grasp. Leaflet length is not an issue here. We just want to get a good insertion.
Okay, if that's the case, let's do it.
I think.
Yeah.
Okay, we go.
Stan, that's what we're going to do.
We open the clip and try again
Yeah.
for more posterior leaflet.
Yeah, so that we're going to go a little bit more posterior so we get a better grasp of the posterior leaflet.
Yeah.
This is where it'd be nice to have independently operating
Yeah.
graspers,
Yeah.
you know?
Gen 4 would have allowed you to do
Yeah,
that.
which is Gen 4.
We're gonna roll now. Show us posterior. Redropping.
Posterior is nice.
More posterior, definitely. Now.
Yes.
Okay, okay. Show us posterior, please. I want to see the ripper bands.
You will see the posterior.
We really need to see the good. Okay, we're gonna close now. Really want
No,
to see the posterior.
you're much more on the posterior leaflet.
Yeah.
Yes,
Yeah.
we are releasing the tension. Okay, you
Okay,
want to put
60.
the color on?
60 now.
You like color?
Put the color, so if we like it, yeah, close.
Okay, we're gonna close now. Okay.
Yes.
Everyone agree? Okay.
Yes.
Okay, looks good.
Closed. And we give back some tension as well. So now you can see the difference on the photo.
Mm-hmm.
So let's measure let's look at leaflet insertion. So what we've done here is that we actually measure the residual leaflet length compared to the native leaflet length to kind of see how much insertion we have.
What do you think, Stan?
Can we freeze it? Let's freeze it. Can we freeze it?
Residual leaflet.
Especially with XTR because of the concern.
Yeah, we measure now. Residual is
0.6?
0.7.
Yeah.
So yeah, so we have about a centimeter insertion.
Yeah.
If
That's
you,
good.
Yeah, and if we're not sure, what we do is we look at lateral and medial of the native leaflet to compare, and then we subtract the difference. So
Okay, if everybody is happy, we'll release here.
Panel, you happy with position?
Yeah, but
you
MR,
looked at the
assess the
MR?
MR, huh?
In all the views? I mean,
Want
you
to see
only
that?
did
Show us each view.
We
show us
usually
the
do
color.
MR assessment,
Yeah,
pulmonary
show us the
veins,
color.
gradient.
and all that.
yes. So 9 degrees.
Probably Rick Nishimura is very upset that you're not measuring pressures. It's like MR, leaflet insertion, MR reduction, pulmonary vein flow, gradients, and 3D end phase before we actually release the clip.
Okay, sure. We are happy with the insertion. You have to give us a gradient.
Leaflet insertion looks very good,
Okay.
2 more thousand heparin, please.
right? The color looks quite good, right?
MR is much better, yeah.
Even Grube is agreeing.
Yeah, mild,
I
mild,
mean,
mild
it looks like just, yeah, very mild MR.
I think it does.
Can you see the pulmonary venous flow?
Yeah, I will check that, Dr. Stone. I'll check
Give us a gradient and a pulmonary venous flow.
that. So, yes.
Looks very good.
And XTR worked out well, you know, it is,
Exactly.
right, it did, yeah.
Mild MR, let's measure the gradients.
Yes, gradient and they want the.
The E velocity is less than the A velocity, right? So that obviously rules out significant MR. And it goes, so the gradient is,
So the gradient is
2.
the gradient is 2 in the lateral orifice. And most likely the same in the
would be
medial.
the same, right? It boils,
And the hemodynamics also looks good, you know, the waveforms are good. The wave is down, you know, the scale is larger, but still it looks much less.
the tracing, I think the,
So we went down from 25
right?
to
The view, yeah.
now 10.
2 and 2. 2 and 2.
How's the pulmonary vein flow? Can you share with us?
Yes, I'm looking. Looks promising.
Yeah. The pulmonary vein flow is very useful to look at.
systolic reversal, and now it's actually almost normal. Systolic wave, and so it's normal pattern from reversal in the right upper pulmonary vein, in the left upper pulmonary vein. And I will see the right upper.
What's happened to the left atrial pressure?
The V wave went from 25 to around 10 to 15. You can see that.
You
Do you
can
see
see it
that?
in the corner.
Do you see that?
Yeah,
on
we
the-
see it.
Yeah, it was 5 beforehand, the V wave around.
So the
this is
mean,
normalized.
the mean left atrial pressure is around 12 now?
Less than that.
Less than, to me, 8.
It's like 8. Yeah.
8.
It was around 15.
What was the mean to start? Like 15?
And Greg, also the patterns changed. You can see that the prominent wave actually is the A wave, and the V wave is actually smaller. Am I right, Dr. Mishra?
Yes.
And the pulmonary veins both
Yeah,
are
the-
normalized. One was systolic reversal on the left upper pulmonary vein, it's normalized. And the right upper pulmonary vein was blended, and actually, as you can see, it's also normalized.
I mean, we're getting, a series of registries that this acute reduction in left atrial pressure and the normalization of the pulmonary venous systolic flow pattern really predicts outcomes. It's very, very helpful. We also have some interesting data from COAP, which will be presented, I think, at the ACC, suggesting that, at least in the COAP population, the mitral valve gradient does not seem to be that critical. In the upper quartile of mitral valve gradients, which are 7 millimeters and above, those patients still had tremendous benefit from MR reduction. So that's not final yet, obviously, but it's very interesting data.
Check the MR one more time when you go to neutral with this XTR. I think is a useful thing.
And then you have to make the case for the second clip.
Yeah, we'll see. We'll reassess.
I'm not sure you need one if there's.
Yeah, you may not, that's what we're saying.
You may not need one, yeah.
You
Yeah,
went in thinking you were almost for sure going to need 2 clips,
No,
but
I
let's see
actually-
what it looks like after the release.
Yeah, I agree with you, Greg and Sybil and the others, because you can see that with the XTL steering, we're almost on top of the valve. So going medial to this would be more challenging.
Yep.
Sure, you need one.
Yeah,
Not,
no, I
not
agree
with,
with you.
not with that reduction in pressure, elimination of the V wave, the normalization of pulmonary venous flow. And we'll see how much MR you have once you release, but it doesn't look like it's going to be much more than 1+.
And then meet.
Yeah, I think we need to look at this from a multimodality standpoint, like all you guys have mentioned, on the not just the color, but also hemodynamics and
Yep.
pulmonary vein
We
flow.
will do the positioning again. Okay, floor.
And as you know, the color can be really problematic after the MitraClip with getting 2 orifices. So it may be that the hemodynamics are more important and the pulmonary vein flow.
Are you on the floor?
What do you guys think about that? How much do you rely on color as opposed to other measures?
I mean, it's an integrated approach. Color is one of the many that you use. Color is very hard after MitraClip. It's not easy and it's difficult. You got to
Yes.
take pulmonary vein flow. But the problem with the LA pressure is it doesn't always change positively either. So you need to use everything that's around. If the LA pressure changes, then it's helpful.
But those cases may mean we haven't done a good enough job. You know, we've
that
never
is
really
po-
been able to validate how to grade MR after the MitraClip.
It is extremely hard, and I just showed one slide before. One of the ways to do it, one way, not the only way, is to compute real-time regurgitant volume,
Right.
pre and post, on color Doppler, which you can do with 3D. And I hope that technology catches because we desperately need something like that. It's very crude post-MitraClip.
Yeah, so the clip is deployed. Sam, you want to assess?
Yes.
All right.
Ready? Careful, hold it.
The end face view? Oh, wow, the MRS looks more now.
Yeah, that's unexpected.
So this, I'm on the clip now.
Silver.
I'm lateral to the clip.
There's also a medial jet, isn't it?
Yes, there's a medial jet.
Touch, please.
Actually, if you explain the lateral jet, it's not very big. I think the medial
It's
jet
the
is
medial
bigger,
jet
which is bigger.
looks like it's going to need to be treated.
the whole jet is on the medial part.
I mean, if the adequate, you can consider putting a small clip.
Interesting too, look at the left atrial pressure. You know, the V wave is much more prominent now too. It's at least the size of the A wave now.
Okay,
Can we see a 3D end face view of the valve?
everybody feels we need a second clip, right?
Yeah.
Okay,
Do you mind if we see a 3D
Let
end
us
face?
look at it because I'm not sure that it's going to be easy.
Can we see 3D end face, please?
Yes, yes.
You have a large medial orifice.
It is not unreasonable to leave it like this and see how patient does. You know, well, because I don't know how easy it is.
I don't know. Why not try to see if you can get a second clip in place?
No, I agree. I think, yeah, here it looks worse, so maybe. Can you look at the ventricular side?
You can put one clip medially.
Small one.
This is not totally unexpected, given the mixed pathology. I mean, in this case.
It went down to 25 to 15.
So on both sides, the lateral is smaller, and I think we should just address.
Medial with a small clip, right?
There is still some lateral jet, though, isn't there?
I don't think space to put two on it.
No.
No.
agree.
I think, yeah.
I would think that one more clip medial is going to get you where you want to go, if you can get the clip there.
Our history search on this patient. Patient has never been in atrial fibrillation. LA has been gradually dilating from 40 to 16 to 22 millimeter square and size becoming up to 4 to 6. But never been AFib. Patient has never been in AFib.
This is a better 3D for you guys.
so we're going to go medial now. Huh?
Can you do a true view, just the other one that you had before?
Yes.
Oh, I like this color.
See, this is good because it shows you that how the P2 came up and there was hole on both sides, you know, where the clefts were.
It's nice to proven that on the medial side. This is a beautiful picture,
Yeah, that really is gorgeous.
right?
You see that little MR jet? Wow.
Yeah, and which is more prominent medially than, but the problem is going up till the P3, no?
Yeah, there's a deep indentation on the P3 side, you know, also because the ventricles are a little bit, dilated, EF is a little bit less, so that's why you see that part opened up. So we'll have to steer past this clip to get to the medial side. Challenge is going to be with the transeptal, given
Yep.
the net environment, we're doing the smaller clip and hopefully we can get past it.
So what you should do is you should try to gain height by using the clockwise in the guide and then using M knob and the A knob to gain height.
Yeah, we'll have to see if we need it. Hopefully not. We'll see.
You can't hear you, Saibal.
Just put a second clip very close to the.
You're going to have to.
Yeah, the biggest jet is medial.
Yes.
But both sides are leaking,
see
huh?
that.
Yes, I
really
think
nicely
both
there.
are prominent jets, I think.
Remember, I was talking, I mean, I know you don't have Gen 4. Why a Gen 4 device, a single, is it better than using two clips? Because the Gen 4 device is 6 millimeters. So it's slightly broader. So you can land up doing one 6 millimeter clip and one NT. Just
But the 6 millimeter is just the gripper is only 4. So
no, the leaflet,
the
it takes
plate
a-
is 6.
Yes.
But the gripper is 4.
So
So
it
you
doesn't
know,
matter. But you're getting, it's opposing the leaflets together. 6 millimeters.
yeah, it is a, we don't know, not enough information because I think it's so new that, and it's very hard to put a clip next to it with a wider. So there are some pluses and minuses. At least, as I said, I've not tried in many. This is just 2 weeks ago that we have it. So we have used like two or three cases.
All right, quickly got ready for the second clip.
Okay. This will be the question, can you turn? We have enough height.
We think so. I think we should be able to get it without any movement, and maybe we need to add a little plus if we need it. I'm coming out slowly.
Okay, we're coming out now, Sam.
Yeah, she,
Straddled already.
Yep.
If you turn as Saibal said, turn your guide posteriorly, the first handle, yeah, the left hand one, yeah. Keep turning posteriorly, even furthermore. And then if you're too posterior, then put an A knob back.
Yeah.
So that will help you. And then if you put A, it will go laterally, so you'll have to put M. Yeah, keep going.
Okay, we're very close to the first clip.
Yeah, if you put a little bit posterior, more for the guide, you will not hit it. So you keep going posterior. Yeah, and now you can use A knob. Yeah, come
There
back.
you go, now you're separating.
Yeah, that's good. I think you are below it. You are medial to it already, yeah.
Yep.
Now check the go. You're very posterior, then instead of putting turning back, maybe use A knob.
Okay, we're right next to the first one. We made it.
Good job.
Okay, so we're going to open the clip now to 60 just to check the orientation. A little bit, you can see that now. Do you think how do you think our trajectory? Do we need plus? Do we need the?
Don't put plus because you will definitely lose height. Yeah, so just, I would put A knob, that put a little bit A. No, the second one, A, yeah. No, go little A. No, more A. No, not that one, yeah.
Yeah, yeah.
Towards, don't put plus.
Yep, there you go. Better, but still out of plane.
I think we're going to go into the ventricle and then we'll make the fine adjustment.
Orientation is, yeah, okay.
Yeah.
Little less M.
Did. Yeah.
Okay.
Looks pretty good there.
Reduce the tidal volume, you'll have less movement of the clip.
Exactly, that's a good point. Can we reduce the tidal volume? What's the tidal right now?
Right.
Yeah, let's go to 400 and then increase the respiratory rate.
Okay. Open the clip now. Your fluoro.
Clip is moved away too medial. You should be a little bit more closer.
Yeah.
Or advance the whole thing, yes. Okay.
We're going to come up and grasp now.
Yep.
3D and facing check.
Yeah. And cup it a little bit, I think you're too flat.
Sorry, I'm sounding like a school teacher.
Release the clip, videos goes on. We release the clip, video goes. Okay, now it's
Drop the gain. Looks pretty good. Can you drop the gain further?
What do you think, Stan?
Yes, it looks perpendicular to the commission. Looks good.
Okay, back to 2D, please. I mean, fluoroscopically, it looks perfect.
Yeah.
I mean, unless the first clip is twisted. Okay, go back to our grasping view. Perfect. Okay.
Good. Okay.
Check the color that this is the right place, huh? It should be, but...
That's only one place this can go, so.
I think, look at that. The posterior, both the leaflets are.
Oh, yeah.
Pulling back.
Okay, we're going to drop now, Stam.
Yes, watch you.
You see the clip? Yeah, you see the gripper bands? We're going to close slowly now. Should we advance a little bit?
Okay, we'll advance. I don't see any change in the V waves now.
Okay, 60.
Okay, you can put the color on.
Yeah, let's put the color.
Put some color.
Okay, we're going to close now completely. Close.
In one view, it's 0 MR.
Okay, V wave come down to less than 10 again, and be with a mean atrial pressure around 7.
Okay, I'm
it's
on the
fine.
second clip. Going, yeah.
Yeah, we'll look at
Yeah,
the
the-
insertion.
Okay, here we are.
Left atrial pressure is low enough now, you should give him some fluids.
Stop the diuretics.
All right, go.
ACT is 308.
Another view.
Yeah, 1 centimeter in. No?
Yeah, I want to see. There was not. What do you think, Stam?
I'm measuring now.
What do you guys think? Clips far
No,
enough?
the insertion is perfect. I think that the most important, check the gradient, which probably will be fine because LA pressure has not increased. And the A waves are not big or anything, so.
Billowing. Do you like that slow billowing there? You think we have enough posterior?
I think so, yeah.
They got. You mentioned it.
Yeah.
I will check.
Posterior
I'm checking
jet
MR.
looks really nice.
I'm on the second clip. Moving,
Give us second clip and the total
moving
gradient.
lateral. No much MR.
Now, if you show us a 3D and see the tissue bridge, that if you are, if you want to see for sure that whether you have enough posterior, but I think it is enough. Just do a 3D. The other way is also to go to 0-degree view and sometimes, but do the 3D first. Let's look at the 3D.
Sam, are you okay with the second insertion, posterior leaflet?
You okay?
Second clip?
Yes, I'm okay. Yes.
Gradient?
Yeah, let me see. They asked me to do a 3D, so let me do a 3D.
3D and
For
then
the-
the total gradient.
On the
Right.
medial side, if you tilt it a little bit more medially.
Yeah, it's good. It basically took the tissue bridge between the medial part of A2P2, right?
Yeah.
It's actually good, and there's still a residual medial orifice, which is nice. And the jet is much narrower, right?
Much less.
Yeah.
Much less, much less.
Little bit on the lateral. Good.
It's a
And
nice,
we knew that
Yeah,
small.
this is what
lateral-
we want to see. Yeah,
Yeah,
this is
nice-
very good.
It's a nice double orifice.
Yeah, and
very
you can see
small
there's a
jet.
very small medial jet. Even
Yeah.
this works. Say that it works.
There's some gradients.
Same too, yeah. It's even not more than 1 meter, so it's good.
That's great.
Two. Okay, we're ready for release, and everybody happy, right?
Yep, we're happy.
It's convinced.
We're very happy. Let's see if after the release, the MR doesn't increase again.
Gilbert, don't kill people.
So it's two in both sides.
So, I mean, why would it be different? Yeah, why would it be different?
What's that, the
I mean,
gradient?
the gradients would be the same on, say, it's a chamber.
There is this thing about the gradient. It's a CW, it doesn't matter. Only the angle of incidence will make a difference. Sometimes one of the orifices more than 60 degrees to your interrogation, that'll give you a lower gradient. But if you're aligned with the orifice, it doesn't matter which orifice you are, it'll be the gradient across the mitral valve.
Or the chamber and both sides are equal pressure.
Pulmonary veins normalized.
Yeah, it was normal before, but remains normal. The left upper pulmonary vein, as you can see.
Pulmonary vein flow looks great still?
Yes, yes.
Remove the clip, huh? Don't open it. Don't open it. Keep it close. I would keep it on the close side. Huh? Don't keep it neutral.
Close, okay.
Now it's too late. Yeah, that's okay. No, for that step, before you remove the clip, if you tighten it for the NT, it stays closed.
I know. They're telling me that the IFU says you have to leave it neutral. Okay, good.
I know the other part different than IFU you can do is to remove the gripper lines first so that, you don't have to tug it.
Yeah, we've done that.
There it goes, nice.
Can we have 2D on the clip, please? Want to look at the pen?
Looks very nice. I mean, and the clips are very parallel to each
Yeah,
other,
they really are.
and they're moving together, which is a sign that the tissue bridge is very strong.
Yeah, it's very nice.
Two clips are in great position.
Okay, boys. Ready?
Okay, come, take this.
Okay.
All right.
Okay, flash, please.
3D image. Two
Okay,
clips.
show us. 3D.
Yes.
Let's see 3D. Let's see some color.
Yes.
Okay. Keep flushing, keep flushing.
Stop. Good.
Great. I think just the little lateral jet is left. The medial is gone.
Yeah, my lateral jet. But
Yeah.
much better, overall much better.
Yeah, also the V wave is 15, the final V wave 15 with a beat of 10. Mm-hmm. And the map now is higher.
Yeah, and maybe if you can check just the 2D.
Arterial pressure has gone up.
Yeah, it did go up.
That looks nice. Very, very symmetric.
Forward flow.
The orifices look great.
Both sides.
They want a final 2D.
Yes.
Yep. Let's see the color on the 2D.
You can also see on fluoral, after the second clip, the first clip is more stable as well. It stabilizes the repair. The map's 96,
Well, it's
so it might
it's much better.
About is better, even with the lateral jet.
Yeah, that's the mild lateral jet right there.
Yeah.
Looks great,
I think
yeah.
if it looks good, we can conclude this case. We're just going to take out the sheath out. Right, Greg?
Yeah, no, I think this is, I think.
Wonderful, yeah.
I knew this was a difficult case, really challenging with, again, mixed degenerative and functional, with some clefts thrown in, and very challenging. You made it look easy. So congratulations. I think this patient got a great result and should significantly feel a little less dyspneic. So fantastic work. Great job. And thank you for the panel for your expert commentary.
They can continue because we are ready for the next case.
I wish we had time for the next case, but we don't.
So it's probably better everybody stays there, and patient is ready. We'll go live with the next two.
Yeah, we can't go live right now, so we're past our time, so we're going to go on to the lectures, and then we'll come back with you. Okay, at about 4 o'clock for the next live case. Thanks.